you can get away without it. So we're going to talk about needling the upper trap. There are commonly two areas where you will find trigger points in the upper trap. One is gallbladder 21. It is right in the center, mid-axillary, or mid-clavicular rather. And we want to use what we call a pincer palpation. So we are grabbing the entire muscle belly and lifting it and kind of strumming our finger across. Right? We know the fibers are running mostly horizontal in this position, and for the best palpation of taunt bands or trigger points, we need to run perpendicular to them. If we're running with them this way, we don't really feel much. So I'm going to pincer between a couple of fingers and my thumb, and then I'm rubbing my finger back and forth. The other location you'll commonly find a trigger point in the trap is right at the base of the neck, right at the base of the cervical spine where it starts to come off. This is sort of small intestine-y, the small intestine channel cuts through here. I don't know, 15 or so, small intestine 15. I tend to needle both of these areas anytime I suspect the upper trap. So I'm going to do this from the far side of the table, whichever side is most comfortable for you. But I'm going to use that same pincer that I'm using to locate those taut bands to needle it. Because the lung is directly under the upper trap, and I do not want to needle her lung, I'm going to lift the muscle up and away from the rib cage. I know I can't pick up the apex of her lung. I'm not going to move her lung by squeezing up on the muscle. So if I lift something and it's between my fingers, I know it's muscle tissue and I can safely needle it. However, be aware of where your fingers are on the underside. You do not want to needle right through the muscle and into your own finger. That's a bad day because you've contaminated yourself and there's no way to take the needle out without contaminating your patient. So don't do that. I'm going to start with this guy out a little further because it's easier to see. And all I'm going to do is once I've located it, I'm going to split my lower fingers. So they're on either side of it. And I'm going to pinch the whole muscle up. And now I'm going to needle in such a way that the needle is angling between my other two fingers. Right? In a sort of standard dry needling class, they teach a lot of pistoning, and they try to get the muscle to fasciculate. That is the sort of most original form of intramuscular needling. What they are learning is that it doesn't actually make much difference in outcome if I get a fasciculation or not, and I don't need to needle it until it stops fasciculating. So in the trap, it tends to be very sore if you do a lot of pistoning. So I don't tend to do much. I may do just a little bit of what we call spiraling, where you're just gently twisting the needle with a tiny bit of lift and thrust, and I got a little fasciculation. If I were doing this on a patient, that'd be enough. I wouldn't do any more stimulation to the needle. I'd let her rest with it for 10 to 20 minutes.
You're kind of good once you get to the fasciculation.
Yeah. Lots and lots of the time, the needle going in causes the fasciculation, and I just leave it. Myopane, one of the big teachers of dry needling for PTs, originally taught piston the crap out of it, slightly changing the angle each stroke until it gives up or the patient says stop because it's too painful. They are moving away from that. Chris and I were talking about an article, a study not too long ago that was looking at the effectiveness of that versus needle, hook up e-stim and let them rest for 15 minutes. And the outcomes are actually better with the gentler approach. So acupuncturists have kind of known that for a long time. And PTs are coming back around to like, okay, we don't need to needle it to death. The fasciculation for me means that I've gotten that trigger point where I wanted it. But it's not, to me, a failure if it doesn't fasciculate. If they get results, they get results. I don't really care.
What about the depths going into the tissue inside?
Well, every tissue is different. Here, you can distinctly feel when you get into that taut band. And
so you can go deep, you can go shallow based on the patient.
Yes, as long as I have lifted it up and I know I'm needling into what I have lifted, I can go till I push out the other side of the skin. I wouldn't go all the way out. There's no need to. But I can needle as deep as I need to. She's rather small, so that's maybe 15, 20 millimeters max of needle. A 30 millimeter needle is usually enough on the trap, but I almost always grab a 40 just because I'd rather have a little extra length and not need it than run out of needle and need a little more. So easy enough. Physical therapists actually originally would mostly needle it, fasciculate it, pull the needle right back out. So they'd turn around and reuse the same needle if they're working on one region up to about 5 locations is what they taught. Now, they do teach if you ever hit a bone that you shouldn't reuse it because it's dull and it will hurt more. Needles are cheap. There is no reason to be reusing your needle.
Do you have your needle kind of angled that way at all, or do you?
Basically straightforward, but it depends on where I feel that trigger point. If it's closer to the surface up here, when I pinch it up, it'll be a little more cranial angle. If it's more directly under where my fingers are, it'll be more perpendicular. I just don't want it going at all caudal.
And then there's no, like, say you were going straight down and then you release it. There's no worry of the releasing it doing anything on it.
I wouldn't piston it once I've let go. If you're gonna manipulate the needle, you do it while holding this. And if I let go and then I'm like, oh crap, I wanted to move that more, I'd have to pick it back up. I generally don't do that because once the needle's in, that can be a little uncomfortable. So I grab it, needle it. If I'm doing any stem, I do it right then and then I let go. But I'm not worried about like the needle hitting the lung because I let go.
Well, often when I let go, I'll do it perpendicular, and then when I let go, it then kind of angles.
It looks like it's in a different angle.
Yeah, I kind of withdraw it a little bit too before I let go. Just I probably err on the side of being overcautious.
There's nothing wrong with that.
Where I'm wondering if I'm going too far and not getting the result that I would want.
If the needle was where you wanted it with it lifted, there's no reason to retract it before letting go of the tissue. It's not going to get into the lung. The tip of the needle's in the same tissue. That tissue is just moved because that trigger point is physically superior when I pull it up. Sorry if I'm torturing you by squeezing too much. I've lifted it, half an inch or so up and it will drop back down. And if the tip of my needle is in that tissue, it's still in that tissue. It hasn't advanced. Even with e-stem, I have never seen a needle actually advance. I have seen them walk out, but I've never seen them go deeper.
Just out of curiosity, what line would you say now, okay, I wouldn't even want to go? Like, where do you estimate the lung to come up?
Well, I don't
Or
estimate.
where would your comfort? So, it's just about where you
I
can
only needle what I can lift. One thing to pay attention to is I actually have to be able to lift the tissue. Now she's tiny and I can easily fit my hand around and lift. But a lot of my patients, that's kind of hard to do.
So hard.
And if they're big and I grab like this and say, I've got just muscle and I go to needle, that's not safe.
Yeah.
If I haven't actually lifted it, I very well could have her lung between my fingers. I do right now. I need to be able to pull that tissue up and create that space to know this is muscle. Everything from here down, I'm not putting a needle in. Right? I may needle down here other ways. We'll talk about transverse needling for middle and lower fibers here in just a sec. But in the upper trap, I have to have picked it up, pincered it, and lifted before I'm safe to needle.
And then how medial or lateral you are, does that really matter?
Nope. Wherever those points are on her. There tends to be one roughly in the middle and there tends to be one roughly here, but you'll find them way out here near the large intestine 16. You'll find them a little more medial. You'll find them in between the two common locations. If she was having severe pain in her shoulder and traps seemed to be indicated and I came in and I found 4 or 5 really tight spots, I might do 4 or 5 needles along the upper trap. Yeah, my personal approach is always to start very gentle. So I tend to, if I have never worked with this person, I'm working on trap, I'll put the needle in, I'll do minimal manipulation, and I'll let her rest. No e-stem or anything. Then I see how she does. If she's a little better, but not a lot, or she didn't have any soreness after, I may get a little more aggressive the next treatment and a little more aggressive until I find the right amount of stimulation to get her to feel better. I don't like the beat the crap out of them and then they're sore for 4 days, but then they're great, so they love you. That approach is not my approach. Gentle, I am amazed how often a very gentle treatment is magic. They get huge change. And if they don't, I can ramp it up to 11.
Time is just about 15 minutes to
Yeah, 15 to 20 seems to be the sweet spot in my experience. So that's what I usually do. And I both have talked about this a few times over the last few years, how the more familiar we get with anatomy, the more cautious we become with needling. Because a lot of what we've done before was sort of like blindly needling into an area, and it seemed to be okay, but do you want to risk that? And so the more skilled we get with anatomy, the more we're extra cautious about what we're doing. Because the last thing we want is a needle fishing around. I'm going to show you a video here in just a bit of a pneumothorax occurring in a dry needling class. And it's an instructor with tons of experience. And to a participant in class, he gives them a pneumothorax. So we want to always keep a healthy level of respect for not doing any harm. And if there's any doubt, find another way to treat it. You know, we're talking about the upper trap and needling it here. It's not intramuscular dry needling, but I can come down and needle all along the acromion and on the clavicle, and those tendinous attachments will have an effect on the muscle. Even just the periosteal needling approach will have an effect. I can come up here and needle all along the occiput on the skull, where it's really pretty safe to needle, and I'm getting all of the other end of those tendinous attachments, and it'll have an effect. Is it as strong of an effect as going right in and hitting that trigger point? Probably not. But if I don't feel like I can safely and effectively get to the trap trigger point, stick to those other approaches.
Kind of very transverse that way, kind of.
For the insertions?
Yeah.
Well, for those, you're over a bone. So you can go
Kind of
straight
go in.
in. Yeah, just short needles right until you touch the bone.
Okay.
Yeah, good deal.
What about the size of the needle? Do you notice the more effective?
I don't really, but I prefer a little thicker needle. 32s are my minimum. That's what these all are. I actually prefer 30s in most cases. I just happen to be out of all my 30s.
You said the thinner needle is what causes that pneumothorax, right?
Yeah. Thin needles, if you're using short needles, like if you're using 15 millimeter or 30 millimeter needles, you can get away with a pretty thin needle. But as soon as you step out of that 30 millimeter length range, I prefer a thicker needle, because a thinner needle is more flexible, and a flexible needle will choose the path of least resistance, and that may be a lung. And I don't want a lung, I want muscle tissue. So I want a thick enough needle that it goes where I tell it to go. And the longer it gets, the thicker I like it. So if you're using like 75 millimeter, 3 inches, or 4 or 5 inch needles, I would prefer to be a 30 or even a 28 gauge, where it's quite thick, you know. But 30 gauge, 75 millimeter, 3 inches is probably the highest I use on a typical day. For the middle fibers, if you know how to needle the inner bladder line, transverse, you know, pretty much laying the needle down, you're doing the same thing. I prefer to strum the muscle and try to feel for taut bands, and she has one here, and then I'm going to lay the needle down just like this. Some people still prefer to try to scoop up those fibers. I don't have much success in the middle and lower trap with that, so I don't tend to do that. But if that's what's comfortable for you, you know, definitely stick with your comfort zone. I just prefer to keep the needle in a nice transverse, shallow angle. Realize that trap is the most superficial muscle in these regions. It's just under the skin. And unlike up here where it rolls over on itself and there's some thickness to it, it's a thin sheet down here. So I don't need to bury a needle. It doesn't matter.
But not.
You could go this way.
Yeah.
As long as you're getting into the fibers. I like to go across fiber because I find I stimulate more fibers that way. But your mileage. The rule is, if you don't know what you're needling, you don't needle it. So if you can't feel the landmarks, find another way to treat it. Absolutely. So the lower fibers, remember they come all the way down to T12. If you have forgotten how to find T12, the quick and easy way is to feel the width of the spinous processes. You can see how narrow this one is and how much wider this one is. That's T12, that's L1. So from here all the way up is trap. Remember though that it's coming to that medial border of the spine of the scapula. So it's quite narrow, it's not way out here. That's iliocostalis and or lat. So I need to be on a line somewhere from here to here, and I'm going to strum for the edge of it. And in fact, I can feel it, though you're going to feel spinalis and longissimus as well. Remember, it's the most superficial. For the lower fibers, I tend to do what we call shelfing, where I fall off the edge of the muscle, I push the tube down and up against the side of the muscle. And again, it's a very transverse, shallow insertion. But like if this is the muscle, I'm not trying to needle here, I'm falling off the edge and running into it from the side. We call that shelfing because it's like you're sitting on a shelf.